Hey, gorgeous. Welcome to season 6 of the Hormone Puzzle Podcast. I'm your host, Dr. Kayla Smith, a holistic integrative doctor specializing in fertility and hormone health. If you're looking for insights into hormones, fertility, and all things related, you've come to the right place. Tune in weekly as we interview amazing experts in the field of women's health, breaking down those hormone walls, nerding out on nutrition, and having way too much fun. Whether you're beginning your journey or you've been struggling for years, we're finally going to help you put those pieces of your hormone puzzle back together so that you can get and stay pregnant and eliminate all your hormone-related symptoms for good. Are you ready? This season, we're focusing closely on fertility and hormone health with an amazing lineup of expert guests sharing groundbreaking knowledge, bringing you stories and advice that will support you in your fertility journey. We're here to lift your spirits, give you a virtual hug and inspiration, as well as empower you to take charge of your fertility and your health. Thank you so much for tuning in and for being an amazing listener. So now, let's get started on your road to transformation. Let's start piecing together your hormone puzzle one step at a time. On today's show, we have Dr. Karli Provost Goldstein. She is a board-certified, minimally invasive gynecologist specializing in advanced laparoscopic and robotic surgery for endometriosis, excision, adenomyosis, and infertility. Her personal journey, shaped by her battles with endometriosis, infertility, and complex surgeries, has fueled her deep empathy and commitment to transformative patient care. As the founder of ESSE Care and Wellness, Dr. Goldstein blends cutting-edge surgical expertise with integrative wellness approaches, fostering whole body healing and empowerment. With advanced fellowship training under a world-renowned endometriosis surgeon and experience in over 1,000 complex cases, she is passionate about providing precision care tailored to each patient's unique needs. Today, we are going to talk to Dr. Goldstein about the hidden link between endometriosis and unexplained infertility. And before we dive into today's show, I just want to say thank you again for tuning into this episode of the Hormone Puzzle Podcast. And if you're ready for the next step in your fertility journey, I would love to support you. You can visit our website at hormonepuzzlesociety.com. You can grab one of our free, powerful resources. And while you're there, you can even book a complimentary call with me right from the homepage. I would love and be honored to help you uncover the missing pieces to your fertility puzzle so that you can finally get pregnant, stay pregnant, and bring home a healthy baby. I cannot wait to connect with you. Now, let's get back to our show and welcome Dr. Goldstein to the podcast. Hey, Dr. Goldstein, welcome to the podcast.
Hi there. Thank you so much for having me.
I'm really excited for this conversation. I know we have a lot of questions around endometriosis and if it's linked to unexplained infertility. So this is going to be a really great show and I'm excited to get into it.
Absolutely.
So let's dive in with your story. Tell us just briefly how you got into this work you're doing.
So great question. I sort of flipped around a lot when I was younger. I sort of always wanted to be in medicine. And then I did a lot of childcare work and I did a year of pre-med and then sort of did too many classes in college and was on the rowing team and waking up at 5 a.m. and I burnt out early. And then I got out of it, ended up coming back to medicine years later after studying art and Spanish literature. And then I did residency in OBGYN after doing osteopathic medical school in New York. And I matched into obstetrics and gynecology and really liked the surgical aspect of it a lot and ended up encountering endometriosis in myself actually when I was a resident and underwent surgery while going through residency. And really during that time, I started, following fertility doctors, and as residents in training, we would all do our fertility labs for fun just to see, to know our numbers when we were late 20s, early 30s. And so it was sort of like, oh, this is going to be fun. We'll check our fertility labs. It'll be great. And when I checked mine, they were terrible. So my anti-Mullerian hormone, it's a marker for the ovarian reserve, just one of several markers, but that one came back as almost 0. And they said, oh my gosh, your ovaries are going to fail and you need to freeze eggs immediately. You're probably going to need donor egg. You're never going to be able to have a baby. And this led me on like a almost 10-year path of dealing with infertility. And so I was not expecting that, but basically my whole 30s while in training, becoming an attending, doing all these things were spent dealing with endometriosis and then that infertility aspect. So.
Oh my goodness. Wow. What an amazing story. But thankfully you found the answers and you identified that early. So hopefully it had a positive outcome and ending. So I love that. Thank you for sharing that story. I know a lot of our audience can relate. And that's what we're talking about today, as I alluded to earlier. Talk to us about endometriosis, and we're going to get into that link between unexplained infertility and endometriosis. But just in basic terms, tell our audience, what is endometriosis?
Absolutely. So endometriosis is a condition where, and it's really an inflammatory disease. It's where cells that look similar to endometrial cells, they're not the same, but they look similar under the microscope. They have the same, what we call glands and stroma as lining cells that grow inside the uterus. And so every month when someone gets their period, they ovulate and release a little cyst. The cyst opens up, the follicle with the little egg in it comes out of the ovary. And then 2 weeks later, if that egg is not fertilized and pregnancy doesn't happen, the endometrial lining builds up and then it sheds as a period. That's what the bleeding of a period is. And so every single month, a patient will go through that, a patient with a uterus and ovaries. And so if they're not on birth control or getting pregnant. And so what happens with endometriosis is that cells that look like those endometrial cells are actually growing where they're not supposed to. And they can grow all over the abdominal cavity and even in rare spots, in different spots in the body, aside from just the abdomen. And so when they grow in those spots, they can't release the same way that menstrual blood can be released in the vagina. And menstrual blood that's released in the vagina is picked up on a pad or a tampon. We can get rid of it, or all of the period underwear that are happening now. But the endometriosis spots in your abdomen are not released. They are staying there and they're really stuck. And the body actually tries to send little inflammatory cells and wound cells to clean them up, and it can't do it. And this contributes to a lot of inflammation, a lot of fatigue. It even can track little fever cells or cytokines there. And so we think that that really contributes a lot to not only just the pain, but the infertility aspect of endometriosis that it can affect the tubes, the ovaries, the overall pelvic environment. It can affect the uterine cavity, how an embryo implants and becomes a pregnancy. And so any one of these spots, endometriosis can play an important role in halting that or harming it or making it more difficult. And it's not to say that all patients with endometriosis will have trouble getting pregnant. Many patients with endo will get pregnant and they'll be fine and they'll carry to term. But we do know that there are some risks with endometriosis if we don't take care of it. And we know that in general, it is more difficult to get pregnant for the endometriosis patient than the average patient without endo. Okay. And then we also know in patients with unexplained infertility that up to 30 to 50% of those will have endometriosis. And so those are patients that have infertility, but the doctor says, your labs are perfect, your tubes look fine, everything looks okay, and there's no answer, and they just keep trying IVF or trying on their own and they're not getting pregnant. Those patients have a 1 in 2 chance almost of having endo, which is quite high, right? If you add in any symptoms on top of that, pelvic pain, painful intercourse, bowel movement trouble, a lot of bloating, sharp pain in the abdomen, really painful cycles that they're missing work or school, heavy clots that they can't really manage with just an ibuprofen, then your chances go up even more of having endometriosis, right? And so those are the conversations that aren't always happening in the general primary care field or in the obstetrics field, or even in the fertility world where they see fertility doctors. They keep going for more IVF, and someone doesn't tell them until years down the road, oh, I think you may have endo,
Yeah. And talk to us about diagnosis. How would we know that we had endo?
So that's tricky. So right now, the gold standard for diagnosing and removing endometriosis is actually involved with a surgery. So it's a minimally invasive surgery, but it involves general anesthesia, being put to sleep and putting little pinhole incisions in the abdomen and insufflating the abdomen with some CO2 gas and looking all around for the endometriosis spots. They are working on many different things, endometrial biopsies, blood tests, all different ways of diagnosing endometriosis without surgery. However, even when we get to those points, those methods of diagnosis won't remove it at the same time, right? So in Australia, everyone's talking about there's blood tests coming up on the market in Australia, not in the US, hopefully later this year, that's supposed to be somewhere in the 80s sensitivity on picking up endometriosis, but these are still probably a long way off from being mainstream in the US and covered by insurance and things like that. It will take a lot of trials and everything to get there. There's a couple little markers that we can do blood test wise. There's ultrasounds and MRIs that will show deep stage disease, but it's the stage 1, 2 that are often overlooked and not seen on any kind of blood test or imaging ahead of surgery,
Gotcha. And so the surgery is the only way to get rid of that, because I know I've talked to a lot of patients in my practice and they're almost scared of that surgery because it is surgery. You're under general anesthesia, as you just said. So talk to us about that. Is that the only option we have at the moment?
At the moment to actually get rid of the disease, yes. So there are a lot of things that can manage the disease. There are a lot of things that we can manage the symptoms with, right? And those things can be used. And I like to tell patients that it's always a great idea to work on nutrition and work with a nutritionist who has a great experience with endo. It's always a great idea to be fit and active and healthy and work on stress reduction and breathing techniques and holistic mindset and acupuncture. And I love having all of these collaborators, pelvic floor therapy, in my immediate hand of providers that I send to and a team for the patient. And so I think those things in life are always great. And even if they don't get you to 100% feeling better, they're going to be a great idea to do for your whole life, even without endometriosis, right? So those are things that we can always work on. But then they unfortunately will not get rid of the disease. It may minimize, and patients may get by for years, though, using all of those methods, and they may be able to get by with the pain and do okay, or even get pregnant. So it's not to say that trying those things is a bad idea. I think it's a great idea, and they should always be used as an adjunct to, proper surgical technique for endometriosis. So.
Sure. And I completely agree there. And that's what we talk a lot on the show about, just lifestyle pieces in general for overall health, but definitely for fertility and endometriosis and infertility. So, and talk to us, I know you talked about some symptoms, painful periods and heavy periods and clotting, but what about silent endometriosis? Do you see that in your practice where people might have just like a low stage 1 or 2 and maybe they don't have any symptoms? And then what do you say to those people? What would their options be?
Yeah, and I see that a lot. And I even see stage 4 patients with silent endo.
Wow.
And I think when you do a little bit digger deeping, it may not be so silent. And I think even after sometimes of cleaning that endometriosis, patients will say, well, you know what, I was having this, or I was having that, or I was having, and so it sort of takes a little bit of deep diving and recognition of those things. So common symptoms are with the period, but not all patients have period pain that have endo. Some patients with endo, if their disease is more around the bowel, they may have more bowel symptoms, and they may be misdiagnosed with IBS or Crohn's or ulcerative colitis, and they go for years trying to do immunosuppressant treatments that aren't working, or SIBO that they took the medications, it doesn't go away. Unexplained things like that where they've sort of gotten this diagnosis, but then they're not really responding to traditional treatments is a big clue for endo. And especially if those are hormone correlated. It doesn't always have to be on the period, but it can also be with ovulation or anytime there's hormone swings, which there are a couple during the month that you will have estrogen surge and hormone swings. And so any one of those moments could really cause a surge in their symptoms. I find a lot of patients have back pain and leg pain, maybe back pain or leg pain with their cycle. Some of them have really heavy pain right before the period for a week leading up to the period, but then the period itself, once the blood is releasing, they actually feel a little bit better. And so everyone's symptoms are a huge range. Some patients may have chest pain, shortness of breath at their cycle. Some may have none of those symptoms and they just have a little bit of pain with intercourse or, something subtle like that, or they have no symptoms and they have infertility, and so any one of those could be part of the endo picture, which is what sort of makes it hard when you have stage 1 or 2 disease and there's no proof ahead of surgery. It makes it very hard. Patients are always nervous. What if you don't find anything? What if you find no endo? What will happen? And I like to say we always, even when we're doing this, we look everywhere, right? I look in the bladder at the camera, the uterus at the camera. I flush the tubes. I clean the ovaries. I do 10 biopsies. I check the appendix. I look at the diaphragm. I mean, there's really no stone unturned. And so when you're approaching it that way, I always find something. Even if I don't find endo, I find Crohn's of the appendix, chronic appendicitis, acute appendicitis, all kinds of things that would cause bowel symptoms, hernias that would cause pain. There's usually, I always believe the patient, there's something happening, when they're there. And with the fertility ones, there's usually something happening around the ovarian environment that's contributing to that, or something with the shape of the uterus or the cavity itself. And so, my motto is really about listening. And, when I go back and I look through the notes and what the patient has said, it's always so on point with where their disease is. They're more left-sided, more right-sided. They said something very particular, and then I go back and I look at it after surgery and I'm like, oh my gosh, look at what they said. And this is exactly where this was. And, it's fascinating, but I like to tell them it's like a roadmap. And so it's like having a constellation map before you go in. And so writing down all of those symptoms is one of the best things that you can do, even when approaching all of this and looking into it, is really kind of keeping track of when these things happen and what your symptoms are and what's going on. And that really helps us to sort of track where it may be coming from,
For sure. And I love that you mentioned, really paying attention to those symptoms, because I think so often people, that's their normal. And so they don't really see it as a symptom. They just think, oh, I just have it, my period's a little painful. I just get over it, take some Tylenol, whatever, but it's their normal. So really doing that further investigation and writing everything down, I think that's a great point.
Right. And I think there's a lot of not intentional, but families passing down on families. We know there's a genetic component with endometriosis. We haven't identified just one gene yet, but we know it's more common. Mothers, daughters, aunts, grandmothers passing it down. And so if they also had all of those symptoms, they're like, oh, that's normal because that's how everyone has it in our family. But maybe the whole family had it, and so back when, grandmothers had this taken out, they would just call it pelvic disease or bad uterus or something, or, oh yeah, their periods were terrible. So after they were done with kids, they took everything out. And no one really was explaining what it was, but this has been around for a long time, so it's just that we're talking about it and putting a name to everything now, so.
Yeah. Sure. And you do a lot of excision surgeries in your office. So talk to us about that. You say that this will significantly improve somebody's fertility. So tell us a little bit more about that and your process there.
Absolutely. So I do them at the hospital, but I work with patients, before going through what they've been through, what they've tried, if they've done IVF, if they've tried on their own, what kind of supplements they've been on, all kinds of different things we review. Sometimes they do fertility trials ahead of surgery. They do IVF ahead of surgery. And I'm very open-minded to whenever that needs to happen. If they want to do those things, try 3 months of this, 3 months of that, and then do this. It's always, and I'm always open-minded about that. There's not really usually finite times of doing this unless there are very, very large ovarian cysts. There's something really happening where I don't think it would be safe to achieve immediate pregnancy. And so I did a case this week, for instance, that was someone that had a prior cesarean section and there was a defect in the cesarean section scar. So they only have one little layer thin of uterus on the front where the C-section was. That would be dangerous for a pregnancy. And so they actually wanted to have it repaired before achieving another pregnancy. So there's certain circumstances like that where we actually recommend, and she was sent to me by 2 other doctors that said, no, you need to repair this and then we'll work on everything else. So that, there's certain situations like that where the OR may be one of the first stops, but more often than not, I'm always there as a resource and then we go in if we need to. I take pictures and videotape the whole procedure so that they can see it. Their fertility doctors can see it. Experts like you can see it. Anyone, that can really have a look at what was happening inside. And there's really no replacement for that. Even operative reports, pathology, all these things, nothing replaces really seeing what's happening inside the pelvis. And so typically, I look inside the bladder, I look inside the uterus with the camera. If there's polyps in the uterus, I always do a little biopsy inside the uterine cavity to check for inflammation and chronic endometritis. And then we look in the abdomen for endometriosis. We flush the fallopian tubes. We check all around the pelvis for endo lesions. And if they're there, we remove them. And any spots that look scarred, inflamed, adhesions between the tubes, bowel adhesions, anything that could contribute to sort of an inflammation or stagnation in the pelvis, I would clean it all out conservatively. And then there's even some tricks that we can do to boost, the ovarian blood supply that I can do in patients that have premature ovarian insufficiency or failure, like I was told I had. And so, there's a lot of little things that we can do surgically to really optimize the anatomy. If the uterus is very sharply tilted one direction, I can correct the angle of it. If they've had trouble with embryo transfers or something, we can dilate the cervix so it's easier passage. There's a lot of little sort of techniques along the way that you can do. And those are always sort of just strategies during the fertility restorative surgery.
I love that. And so would you say if somebody is experiencing unexplained infertility, this is something that they should definitely do just to mark this off the list and say, is it endo? Is it not? This could be the reason for the unexplained.
I think if they've been through a lot and really are on like their last, they've just been through too much and too much loss and there's really not options left, then I think it's definitely a resource. And to think about 1 in 2 or 50%, it's quite possible, and those are the data that we have from patients that actually underwent a laparoscopy. So if we actually we don't have the data of every patient with infertility undergoes a laparoscopy and sees if they have endo. If we had that data, it may even be higher. In the 90s, they used to do that for patients with infertility. They would go in and look, and then if there was something wrong, they would fix it. Then once rapid vitrification or rapid freezing of embryos became better, and the embryo and IVF results were much better, then they started saying, okay, no more surgery. We're just going to do IVF for everyone. And that may be great, but it doesn't always work, right? And so I get the patients really that come to me at, 6 years of IVF and they're 42. And that's really hard because that's at that point a Hail Mary pass, that I am like really doing everything possible, but I'm really hoping they have some embryos banked or they're open-minded to donor at that point because we're fighting the clock on the ovaries, And so I think that it's a great strategy, definitely in the 30s, whenever they're really trying, things are failing, they've had miscarriages, multiple miscarriages, those don't happen for no reason. When you rule out every single blood test and autoimmune disease and pathology that could have caused it, and there's no reason, unexplained, then endometriosis is highly likely,
Sure. And I know this is on a case-by-case basis, but can you talk in general terms? What is the recovery time? So say somebody comes in and does this surgery, when can they start trying again?
Sure. So I have patients that do this all the time, and they try typically 2 weeks after surgery, they can start trying again. And so, I have several data points of patients actually having pregnancies within a month after surgery. So that's very exciting. And so there's not anything typically that I'm going to do that would cause a long wait time unless there is a big fibroid taken out or there's actually uterine surgery where we have to reconstruct the uterus itself. Then we allow longer healing time for the uterus as a muscle to heal because it will be growing and we don't want it to grow against suture sites that are not healed yet. And the sutures take about 3 months to heal. The data on most of the studies is that within 3 to 6 months, you can get pregnant. However, like the case I did yesterday, the isthmusal is a patient that had a C-section scar again. I took it out and revised the whole C-section scar. So that one I would almost wait closer to a year, Probably the data is 6 months, but if we want to be really safe, then I would say closer to a year, just like we recommend for C-section patients waiting a year until the next baby.
Gotcha. Oh my goodness, Dr. Goldstein, I could talk to you all day. We do have to take a break, so we're going to do that now, and we're going to come back and just talk more practical tips on optimizing fertility with this topic in mind. So we'll do that more when we come back. Can I tell you about one of my favorite brands? They're called Wellness. And as a holistic fertility and hormones doctor, I always remind my clients what goes on your body is just as important as what goes in your body. That's why I love Wellness, spelled with an E, because they have personal care products that are clean, non-toxic, and actually work. Things like toothpaste, shampoo, deodorant, and body products that support your health instead of harming your hormones. So head on over to wellness.com, and that's wellnesse.com/puzzle to shop my favorites and feel good about your daily body care choices. Hey, Dr. Goldstein, welcome back.
Thank you. One more thing I forgot to, I don't know if I properly answered your question, was that the recovery time in general, this is a procedure performed in the hospital or a surgery center. Typically, the patient can go home the same day, or if they're staying in the area, they can go back to their hotel the same day after being in the hospital for, several hours during the immediate post-op period. There's usually a couple days of bloating and gas pressure into the shoulder from the laparoscopy, but most of the time the incisional pain is manageable and not that bad. Most patients I have on a stronger ibuprofen and Tylenol, and then bowel medications to keep the bowels moving regularly. And that's really all they need for post-op. Most of them travel home within 3 to 5 days if they're in the area locally, and really up and walking around that day, showering the next day, all of those things like that. So this is minimally invasive, so it is expected that and encouraged that you're moving around. Most patients are back to trying after 2 weeks and back to work after 2 weeks. Some, of course, recovery is a pendulum, and some may take a little bit longer, but that's in general the sort of outlook on actual recovery time. And I have a lot of fertility patients that sort of were scared and led to be scared that surgery is very, very invasive by their fertility doctors. And then when they had it, they were like, oh, this wasn't really that bad. My bloating wasn't as bad as the egg retrieval or something, and so I would say take it with a grain of salt. Fertility patients are super strong, and I know they've been through a lot, and they're made to go through all kinds of procedures while awake. And this is one of those that you're actually asleep and comfortable. And so I find that in some ways that's way easier than all of the things that they expect you to go through awake as a fertility patient. So.
And I'm so glad you said that, because I have these conversations regularly about people thinking they might have endo and they want to do the surgery, but they're scared to do it. And I kind of have to talk them down. So I'm glad you gave us that, that point of reference. I think it's really helpful. Absolutely. Yeah, for sure. And then talk to us a little bit, we talked some practical tips in the first half, but maybe just summarize just some things that people can do at home, with diet and lifestyle, any recommendations there just to make sure that, we're as healthy and as fertile as we can be.
Absolutely. So a lot of patients will use fitness tracking things like the Apple Watch or the Oura Ring to really track their cycles. Sometimes ovulation test kits are off. I think it's a really good idea to track your cycles and know how long they are. If they're average 28 days and we think you ovulate around day 14, great, but not everyone ovulates exactly on day 14. And so I would say if your cycles are irregular, then it's quite common that ovulation may be off for a few days. And what I typically tell patients when they're trying is that if we're counting the first day of their period, if full blood is day 1, they should really start trying at about day 7 or 8, which is earlier than what most people would say. And if you're trying on day 7 or 8 and you're trying every other day, then that really allows, in case there's an early ovulation, we'll still catch it within the window. Sperm live 5 to 7 days and need to sort of be there waiting. An egg lives 24 hours and then it's gone and you've missed that window that month. So one of the most common things I see is that if someone's just relying on ovulation test kits and they don't come up positive or they fail, then they may have already ovulated, or the test kit may not be working and they've missed the window that month. And so I think it's always better to start on the earlier end on day 7 or 8 and get ahead of the ovulation rather than afterwards. And so I think that's great. You can track the temperature and the ovulation kits. I've seen some patients do like an app with little things that they're peeing on. And it says estrogen, progesterone levels, supposedly. It should be pretty accurate with the urine. I don't have one that's better than the others, but I've seen sort of anecdotal data from a lot of different patients. It is neat to see the hormone surges and things like that on there. But I would say at least that trying from day 7 is just a helpful thing that anyone could do at home easily,
Sure.
And then healthy lifestyle, reducing inflammatory foods, reducing processed foods and added sugars, I think is always a great idea for not just patients with infertility, but endo or anyone in general, reduction of diabetes and things like that. And so finding things that are not artificial sweeteners and a bunch of additives and looking for things around you and brands and things like that you can have, or if you will have, instead of getting process electrolyte water, have water and put some lemon juice in it, and you sort of have a makeshift lemonade, things like that are easy to do. And shopping at farmers markets are great because it's local and in season fruits and vegetables and meats and things that would be locally sourced. If you're at the supermarket, really staying on the periphery most of the time, which is where all the fruits and vegetables and produce are, is a easy way to kind of remember it. And really incorporating mindfulness, exercise, increasing your heart rate, as much as we can. If you don't have time and work is difficult and you don't have time to get to the gym every day, it's still important to incorporate 3 to 4 days a week of doing something you can do at home, right? And I am a perfect example of that. Was years without going through all the infertility stuff and not really being able to work out a lot and being a resident and being a surgeon and all these things. And this last year of like home weights at home, I'm working with a trainer on FaceTime and I'm doing it. And it's like 30 to 40 minutes, but I can be consistent because it's at my house and I can get all the weights here and I can do it, right? If I was going to go to the gym, it's not going to happen every day. And I would fail on that majorly, And so it's just finding whatever sweet spot it is that you can actually get that done. And it's really important. It's great for your mental health, but it's really great for your body and for lowering inflammation and helping with fertility. And I think there's a lot of nutrition resources out there that we can work with. I think acupuncture is really great. There's a lot of data on acupuncture and infertility and improving rates. And, there's a lot of different supplement trials and things like that. The biggest one I know of from the fertility practices is really ubiquinol or CoQ10, a good prenatal, fish oil, and, vitamin D, B12, make sure they're optimized and thyroid is optimized. I think these things are always important and kind of baseline things to consider with fertility.
Sure. And those are wonderful steps and things that we can do at home. And I love that you say, just get it in. If you have to get weights at home or if you want to go for a walk around the block, there's always a way to get some movement in. So I think that's really important. And one thing that we didn't talk about earlier, which I wanted to mention here, do you have any data around if you do an excision surgery, what are the likelihood of it coming back, the endo coming back? Like, what are you seeing in your practice with your surgeries?
Great question. So if we do really, deep investigative look for endometriosis, the most common reason I see patients come back years down the road, and I would say that's the time that I would really reoperate, is sometimes I have patients that come back in their 40s with adenomyosis or disease in the uterus itself. And even when I've gone back and done their hysterectomy or their surgery later down the road, I don't see a lot of recurrence of actually those earlier endo lesions, which is great news. But I do think that at some point down the road, many patients with endometriosis may have adenomyosis, which is like a sister disease where those cells are not growing in the cavity where they're supposed to again. They're growing in the walls of the uterus instead, like where a fibroid would grow. But it creates a cystic lesion in the wall, and that causes incredibly painful periods, uterine pain, painful intercourse, things like that. And so I would say that down the road, I see patients that may come back with that, or that we knew it was maybe there in little small amounts, but they got through, they went through years, they went through their fertility things, they have their kids, they did IUD, they did all different things. And then at some point they're like, okay, that's enough. And then we look into it and it's maybe the uterus itself at some point,
Gotcha. And again, I feel all of the pieces that we mentioned earlier with the lifestyle and the diet, that's only going to put you one step further away from that coming back. I know that there is a hereditary component and that could be a factor, but a holistic diet and lifestyle is only going to help us.
Absolutely.
Yeah.
Yeah, absolutely.
Oh my goodness. Well, I could talk to you all day, but we do have to start to wrap up. There's a few things I want to do before we do that. First, I just want to tell you thank you so much for being here. You're just a world of information, and I could literally talk to you all day. So thank you.
Absolutely. One of my favorite topics is infertility and endo. So no problem.
Love it. Oh my goodness. Well, before we close, I just want to play a little game. I love for our audience to get to know you personally. So we'll do a little game where I ask you a series of questions. Are you open to that?
Yeah, that's fine.
Awesome. So how it works is I'm just going to ask you these questions. You say the first thing that comes to your mind. You can skip if you want to skip one.
Okay.
All right. Favorite food?
Unfortunately, French fries.
Oh, at least.
I shouldn't have them, but I do really like them.
Love a good French fry. How about your least favorite food?
That one's harder. I'm pretty open-minded to different things. I don't know if I have
You can pass if you don't have one.
We'll pass on that one.
Okay. How about your favorite vacation spot?
I really like, I have to say, well, Italy is a top one, and I really like Grand Cayman. The beaches there are beautiful. So quiet beaches are really nice.
Yes. And how about a bucket list item you want to do this year or you're doing right now?
Bucket list. We are going to travel to Europe this summer with the kids, so that'll be fun.
I love it. And then last question, something or someone that you love.
Oh, well, that's easy. My little ones, they're quite the miracles, and it took me a long time to get them, but I'm very lucky to have 2 little girls. So.
Oh, I love that. Amazing. Well, tell everybody where they can find you and learn more about your work.
Absolutely. So our website is ESSE.care, ESSE.care. You can put www or that HTTPS one in front of it. And on Instagram, they can find me, or TikTok, with the handle Patient Surgeon Mama is my handle. And they can find me on any of those. And we do a lot of education things on there and on the website as well. We have a lot of blogs and publications and things on the website for more information. And so we love to do that.
Amazing. And we'll put all of those links in the show notes so the audience can find those really easily and grab all your free information and learn more about your work. And tell us too, if they're in your area, where's your local clinic if they wanted to come and talk to you about their endo?
Absolutely. So I do telehealth all over the US and all over the world, actually. So I'm primarily based in New York, Connecticut area. I also see patients in LA. I'll be out there operating for a few weeks in early July. So I sort of do East Coast, West Coast. I am licensed in some other states as well. So I may be doing the South soon in Texas. But for right now, it's mainly East Coast, West Coast and telehealth, and then figuring out the travel plans beyond that.
I love that. It's amazing. Well, any final thoughts, any piece of advice you want to leave us with?
No, we are doing a webinar, a free webinar every month as well that you can find out about on Instagram or on the website. And so patients can always register for it, and then we'll send the recorded link later too if they can't watch it on time. But we're trying to do as much as we can for different experts in all different fields of endo. This month, it's going to be on infertility and endo with Dr. Amy Ezvadaya, the egg whisperer in San Francisco, which is exciting. So every month I'm picking another expert and actually a real patient with endo as well. And they're going to come on and tell their story and talk about different things. So we're doing nutrition, acupuncture, lung disease, infertility, all kinds of different aspects of endo. And so we're doing a long series of that over the year. So that's exciting.
That's very exciting. And again, we'll put that in the show notes so that everybody can find it really easily.
Perfect.
I love it. Well, again, Dr. Goldstein, thank you for being here.
Thank you so much for having me. It was lovely. Have a great day, okay?
You too. Thank you to everybody who's Yeah,
good luck to everyone. I hope everyone's dreams come through with what they're looking for. And if we can be of any help, let us know.
Yes, I love that. And I just want to say thank you to the audience for being here and for listening to this episode of the Hormone Puzzle Podcast. We're so grateful for you, and we hope you have an amazing week. We'll see you next time. So bye for now. Hey, hang on a second. Before you go, I've got some fantastic free resources waiting for you over at our website, all designed to support your journey. When I was going through my own 2 years of infertility, I wish that there had been something like this to guide me. There just wasn't. And that's why I created these resources specifically for you. And here's a little secret. The strategies and the foods that I share in these resources are the exact same ones that helped me conceive, not once, but twice, even after being told that it wasn't possible. So trust me, I know these tools work. Make sure you check them out, and I can't wait for you to be my next success story. Thank you so much for joining me today. And don't forget to check the show notes of this episode. If you enjoyed our time together, please hit that subscribe button and leave us a review. This would mean so much to me, and it's how more people just like you can find our show. See you next week on the Hormone Puzzle Podcast.